Hello and welcome to my YouTube channel. Continuing our series on short videos, which I have been covering since last 1 week, I would be talking today on one very important topic, and that is deciphering axillary level lymph nodes. Now, here, in my last, if you remember, if I had made one video about the breast carcinoma in the past. Here in this video, I would be talking only focusing on the axillary lymph nodes and its clinical levels and what is its relevance in managing a patient with breast carcinoma. So it would be a very short video where we would be talking about the clinical levels as well as a little anatomy about the anatomical considerations of axilla, which is very relevant in a patient of breast carcinoma. So let's get started. Now, if you see what is axilla, the boundaries of axilla, the structural boundaries of axilla as shown in this diagram. Now, axilla, the apex of the axilla, the superior part, what we mean, is bounded by the convergence of the clavicle, the first rib, and the upper edge of the scapula. That forms the apex of the axilla. Whereas the floor of the axilla, which is the inferior part of the axilla, is covered by axillary fascia and skin crease. Axillary fascia and skin crease. So this is like a superior and the inferior. If you see, superior is by the convergence of first rib, clavicle, and upper edge of scapula. Inferiorly, we have the axillary fascia and skin. Now, anterior is the pectoralis major and minor muscles. That forms the anterior wall of the axilla. The posterior wall is formed by the posterior group of muscles like subscapularis, latissimus dorsi, and teres major muscle. So these are the posterior group of muscles which form the posterior of the axilla. The medial wall is obviously formed by the chest wall, which consists of ribs and the serratus anterior muscle. So the chest wall, ribs, the intercostal muscles, and the serratus anterior muscle forms the medial wall of the axilla, and lateral wall is formed by the intertubercular sulcus of the humerus. Intertubercular sulcus of the humerus. So these are the boundaries of the axilla in a nutshell. If you have understood this as shown in this diagram, then it would become very easy for you to understand the levels of the lymph nodes, the axillary lymph nodes, which we are going to talk in subsequent slides. Now, this which we normally taught when we are doing our discussion on breast carcinoma, especially a theoretical discussion. Anatomically, we divide the axillary lymph nodes into the anterior axillary lymph nodes, the central axillary lymph nodes, the apical axillary lymph nodes, the posterior axillary lymph nodes, and the lateral axillary lymph nodes. So these are the 5 groups of anatomical, you can say, types of axillary lymph nodes. The anterior axillary group is situated just behind the anterior axillary fold. The central group is situated within the fatty tissue of the axilla in the center of the axilla. Apical is towards the that means at the convergence of the first rib, the clavicle, and the scapular bone, whereas the posterior group is situated just behind or posterior to the posterior axillary fold. Whereas the lateral, if you remember, excuse me, remember the lateral group, which is formed by the intertubercular sulcus humerus. So the lateral group of axillary lymph nodes are along the this medial part of the humerus. So this is the anatomical group, but mind you, anatomical group, when you put it into the clinical practice, sometimes they may have their limitations because they would not tell you the prognostication of the patient of breast carcinoma, which a clinical level would be able to tell you. So for prognostication purpose, we normally use clinical practice the clinical levels of lymph nodes, like in the cervical group also we use the clinical level. So these are the clinical levels, what we call Berg's levels. And what are the Berg's 3 levels of axillary lymph nodes? We'll see one by one. But the main landmark of this classification is the muscle, which is a pectoralis minor muscle, which is a definitive surgical landmark, which is used to divide the axillary lymph nodes into 3 different levels. what we call as Berg's classification. Now, what is the relevance? I've already told you of this classification system which is used in clinical practice. It would dictate staging. It would also tell you the prognosis, and it would also tell you the surgical clearance boundaries for breast carcinoma as well as for other types of malignancies. So that is the importance of this. So number one importance or relevance is that it would tell you prognosticate the disease. That means if a patient with a level 3 lymph node is involved, then the prognosis for that patient is poor as compared to only a level 1 or level 2 involvement. Second is it would tell the staging. So a higher stage means a more higher level of lymph node would be involved. So a patient with stage 3 or a patient with a class 3 of type of lymph node involvement would have a worse staging than a patient with only class 1 or class 2. And of course, it would tell you the boundaries of surgical clearance. So these are the relevance why you divide it into different levels. What is the surgical principle behind this? The standard axillary lymph node dissection routinely clears levels 1 and 2. Level 3 is only cleared if extensive macrometastasis is confirmed. So let's go into the what are the different levels. We have seen already in this diagram how the pectoralis muscle, minor muscle, would help you in classifying it into these three levels. So what is level 1? Level 1 is, these are the group of lymph nodes which lies inferior and lateral to the pectoralis minor muscle. Inferior and lateral to the pectoralis minor muscle. That means this includes the external memory, the scapular, and the lateral group. This is the first zone which is reached by sentinel flow. What is level 2? Level 2 is posterior to the muscle or deep to the pectoralis minor muscle. These are located directly underneath or deep or posterior to the pectoralis minor muscle. And this zone also includes the rotors interpectoral nodes, which are located between the pectoralis major and minor muscle. And level 3 is situated above, that means superior and medial to the upper border of the pectoralis minor muscle. And this may extend right up to the Halsted ligament at the apex of the axilla. So this group corresponds to the apical group of anatomical classification, level 3, which is superior and medial to upper border of pectoralis minor. So that's how the pectoralis minor divides it into these three levels: level 1 inferior and lateral, level 2 posterior, and level 3 superior and medial to pectoralis minor muscle. Now, there are certain important critical nerves, the do not cut zone in the axilla, which as a surgeon you should be very, very careful about. The three important nerves which are important to be preserved, if by chance, if there is any problem in the cutting of these, or if any accidental transaction of these nerves, this can lead to a lot of complications subsequently. So we have a long thoracic nerve which runs down the medial wall on the surface of serratus anterior. Long thoracic nerve which runs down the medial wall on the surface of serratus anterior. The injury results in winged scapula, the loss of serratus anterior function. The second nerve which should be preserved and very careful about is thoracodorsal nerve. This nerve travels more laterally to supply the latissimus dorsi muscle. Injury of thoracodorsal nerve, which supplies the latissimus dorsi, may limit the internal rotation and adduction of the shoulder. That means you cannot scratch your back. Internal rotation and adduction of the shoulder. And the third nerve which should be preserved is intercostobrachial nerve. Intercostobrachial nerve, which crosses the axillary space. Frequently, it may be transected during clearance, resulting in permanent numbness of the inner upper arm skin. So these are the three important nerves: the long thoracic nerve of Bell, the thoracodorsal nerve, and intercostal brachial nerve. Now, in this video, we can see clearly these three important things. One is the thoracodorsal nerve, the long thoracic nerve of the Bell, and the intercostal nerve. These are the three nerves which should be preserved in such axillary dissection. With that, I come to the end of this video. If you have liked this video, kindly subscribe and share with your colleagues. Thank you for watching. Thank you for your time.